Thanks very much, Tim, and thanks again for inviting us to speak today, and thanks for the introduction. Next slide, please. Oh, there's a few there. So between us both, between myself and Chris, we're going to be talking about capacity and demand in urgent and emergency care, and there's two separate parts to our presentation. Chris will present the work he's done. Just back one slide, if that's okay. Chris will present around the model he's developed over the past few years, matching capacity and demand, and really focusing on actually preventing escalation in the first place. And that's the holy grail for all urgent and emergency care services, is to prevent escalation in the first place. And then I'll be talking a bit more around what options we have available to us, what we can do during periods of escalation, and what we can do differently to match capacity and demand on a kind of hour by hour and a day by day basis. Next slide, please. Before Chris speaks, I wanted just to say something about harm, and from my perspective, apart from exit block and crowding that we've heard plenty about today, I'm convinced the most harm is caused by delays in assessment and treatment. And that harm comes in two forms. One, undoubtedly, is around ambulance handover delays. We've heard about that already. That delay in assessment of genuinely undifferentiated patients should be of concern to us all, and we should do all we can to prevent that. But there's definitely something about delays in assessment and treatment in secondary care, and ensuring that our rotas are evidence-based and fit for purpose is key to minimising this harm to patients. Over to you, Chris.
Great, thanks, Dan. So as Tim said, my name's Chris Green. I'm the head of informatics for the Emergency Care Improvement Support team, and I kind of want to echo a lot of the comments that have already been said from Adrian and from Dan and from Ben, particularly from a clinical perspective, is that the NHS almost lives in a self-fulfilling prophecy where we get crowding in the emergency department, so we have more patients in the emergency department. And what does this lead to? So it leads to an increase in the amount of time that patients might wait to be treated by a senior clinical decision maker. And what might that then lead on to? It leads on to a high propensity to admit the patients, put the patients into any bed because we want to increase flow, so we might have more outliers. What do outliers lead on to? We know from the evidence that has been talked about for the past few years is that if a patient does become an outlier, they have a higher length of stay, and then therefore we get this vicious circle of occupied beds increasing, adding more pressure to the system. But the question is where do we kind of cycle? And if we just go on to this next slide, I kind of want to talk about, not necessarily from a performance perspective, but more about, as Dan was saying, about the harm that leads on to patients. So we know that the longer the patients wait in the emergency department, the higher the risk of mortality, if either in the department or when they become admitted. And this is a piece of work that we did for an organisation a few months back. And what they wanted to have a look at was there a correlation between the numbers of patients in a department and what leads on to, and I've classified this as a 4-hour standard, but you could kind of lead us on to anything else. And what we've highlighted here is every dot is every hour over a month period. And those dots in black are on a Sunday morning at a particular period of time. And what we wanted to show was we wanted to show the correlation, because the higher the occupancy, so on the x-axis, the higher the occupancy, the worse the 4-hour performance. Because what we want to be able to have is we want to be able to work from an evidence-based, not just a theory base, not just a we think, we feel, which is great, and we really need to know exactly what's going on the shop floor. However, if you can back that up with hard data, with real evidence, it's an incredibly compelling story that we can go on to tell other people about. If we could just go on to the next slide, please. So as Dan was saying, a tool that's been developed over a number of years. So I used to work in an organisation and a hospital, and we wanted to put a business case forward around some more staff in place. But there was nothing really at that time that enabled us to say, well, do we have enough staff? Are they on at the right time? What's the productivity, etc., etc. And so I developed this tool a number of years ago, and it's been used at around about 40 to 45 organisations around the country over the past few years. And what it takes into account is 3 variables. So we've got the amount of patients that we are currently coming through the front door, and that's taken into account by time of day, by day of week. We then have a look at the amount of staff that we have on, and those staff can be changed. So it doesn't have to be consultants, middle grade, SHOs, juniors. If you've got different types of staff, you can put that in, and the model will automatically update. And then the third and probably most contentious issue is around productivity of those staff. And this isn't an individual productivity. This is about how many patients the consultancy or the middle grades or EMPs. And one thing, and I was chatting to an organisation today who want to use this tool for a business case they're writing, is that they started quoting me figures that they have seen in published documents about, well, our consultancy X and our nurses see Y. And I said, but does that happen in your organisation? I said to them, it has to be real. Don't go quoting figures that you think you want me to hear. It has to be real for your own individual organisation, because if you're trying to prove something, we want to prove it. We don't want to kind of say, oh, well, because of X, Y, Z, it doesn't actually happen. So it's really important to take that into account. This model can be up and running in with around about half an hour. So this organisation I work with today, we are in an hour. We are on a Teams call. We had it up and running for them, and they're starting to write their business case already by the close of play today. If we just go on to the next slide, please. We've also got other areas in which we can help with demand and capacity. So over the years, I've developed tools that can help with both ED staffing. That's both from a functional capacity element, but we've also got physical capacity tools as well. So actually how big something should be. So we've been working with organisations to discuss how big their short stay or assessment bed modelling should be, how big their SDEC environment should be, and then equally around long range bed modelling. I worked with an organisation over the past couple of weeks around about what might next year look like, and actually going into the winter of 21-22. And we're enabling that organisation to even then put into their improvement ideas so they can generate scenario modelling, so they can say, what if we made these changes and what difference could it make to our bed models? If we could just go on to our next slide, please. All of these tools are available on the ESIST NHS Futures website, and there's a link on there. And there's also my contact details if anybody would like to get in touch with me. I'll now just hand you over back to Dan.
Thanks, Chris. So sometimes, despite all the best plans in the world, well, in some trusts it's often, but from time to time, demand outstrips capacity, and that might be because we've got our theoretical rotas right, but we have sickness or we have excess demand above the 80th or 85th centile. So in that situation, what options do we have available to us? And I'm going to talk about a few solutions. None of this will be kind of groundbreaking stuff that you haven't heard before, but these are all examples of good practice, which trusts like Sherwood Forest are doing every hour and every day. And if we get these incremental bits right, we can minimise our chance of going into escalation at all. Next slide, please. So for me, there's two options here. One is around increasing capacity, and the second is about reducing demand. And increasing capacity might be staff, it might be space, or it might be other resources such as imaging, for example. Next slide, please. So when we think about capacity in terms of staffing, can we do anything to increase staffing within the emergency departments or staffing within particular specialist areas? So from an ED perspective, is the issue and the challenge and the bottleneck, is that medical staffing? Is it nursing staffing? Is it both? Really important, and trusts that do this well have kind of extremely good plans for how they communicate staffing gaps and the ask for staffing. Might be WhatsApp groups, it might be electronic kind of self-rostering, whatever those options are, there are some really good examples of good ways to escalate. Can we ask our staff, and we try not to, but can we ask them to work an additional couple of hours to get over a particularly challenging period of time? So what can we do in the very short term to get our ED emergency department staffing right? There might also be things we can do around specialty staffing. So that might depend on the case mix. What's the case mix at that given time? Is there a particularly high proportion of orthopaedic patients or paediatric patients where we can ask for a short duration of time to get additional specialty support down in the emergency department? Or can we move those patients to an assessment area outside of ED? Use our resources and our valuable but often limited resources in the most appropriate way. Next slide, please. So there's also the other option is around increasing capacity in terms of space, and that might only be temporary, but there may be ways in which you can increase or adjust space depending upon your the limitations you have in your individual trust. So examples that I've seen work well might be opening up fracture clinic for minor injuries. If you've got a high proportion of wrist fractures on an IC day, can we open up fracture clinic and actually divert a cohort of patients to be seen by a specialist directly in a co-located fracture clinic? Can we convert clinical areas for fit to sit? Can we use 1 or 2 major cubicles? And that's tricky during COVID, clearly. But what can we do within the physical footprint of the emergency department to use our space in a more effective way? Can we increase same-day emergency care capacity? It all depends on where the bottleneck is. None of this is easy, but it may be possible in certain departments depending upon the footprint. Next slide, please. There's then something about what can we do about demand? So thinking about this in terms of capacity and demand, there's really only 4 main factors as to what helps to influence demand in our emergency department. I'd argue the 3 in red here are difficult for ED and even for the acute trust to control. It's hard to change, certainly in the short and medium term, to change the catchment area of the population. It's hard to change the age profile of the catchment population, and it's incredibly hard and will take years potentially to change the level of deprivation within the catchment population. But there's certainly something, and again, very tricky within sort of hours or even days, but there's certainly something about alternative sources of urgent care within the locality. Can we start to use urgent treatment centres differently in the very short term? Can we do anything differently around primary care? Clearly, that's moving. We need additional resource in another area, almost certainly, but that's something to think about kind of quite strongly. Next slide, please. Some of the pictures haven't come out here. That'll be my IT skills. So just that's fine. That slide there. Thank you. So options we've got available in the short term may well be any of the following. So again, it depends on case mix. So can we use same-day emergency care differently? Can we flex our criteria? Some of that comes down to risk and the risk profile that Ben and Simon eloquently talked about before. Do we have options to not admit that patient overnight and to use hot or outpatient clinics to prevent admission and bring them back to see a specialist in the morning? What can we do to flex and change our availability of cross-sectional imaging, as a CT or MRI or similar? Can we flex criteria for UTC, or even I've seen trusts, and I've worked in a trust where we would often we'd have a physical constraint within the emergency department, but actually would be able to flex our staffing to actually move into the UTC and see patients around there with our own staff. And what can we do from a primary care or community care perspective to manage the patients in hopefully a saner or a better way, but during times of escalation? Trusts I've heard about, and certainly working currently, actually, we have such a simple thing as having an Epic phone for the emergency physician in charge, and so ambulance crews will phone. And often I was on call at the weekend, and I probably had 8 or 9 phone calls over the weekend from the ambulance service, of which 5 or 6 we can keep at home. And that may be slightly more work for the paramedic crew, but actually it's better for the patients and it's better for a crowded department. So they're all things we can do in the very short term to increase our capacity to deal with the demand. Final slide, thank you. So I guess finally, in conclusion, I keep this pretty short and sweet, really. Please work hard to develop evidence-based rotas to meet demand. Chris and myself are both really keen to support any acute trusts who want to develop and take this work forward. Getting this right, and getting your rotas right will absolutely go a big chunk of the way to preventing escalation in the first place. If you are in a position of escalation, then it's definitely worth thinking about things from a kind of demand and a capacity perspective, sort of staffing and space. And I guess finally, it's worth just reiterating the importance and value of this work. It's important because it makes a difference, and it makes a difference to both our patients and our staff.